My name is Sal Parascandola, and I'll be presenting on minimally invasive approaches to rectal cancer and an analysis of rates of conversion between laparoscopic and robotic approaches. I have nothing to disclose. The management of rectal cancer is highly individualized, involving various sequences of multimodal therapy based on the stage of diagnosis. Despite advances in therapy, however, the cornerstone of treatment remains curative surgical resection. This includes resection of the primary tumor with adequate negative margins and complete lymphadenectomy of the associated lymph node basin. While the principles of a total mesorectal excision have not changed, technology has, and the introduction of minimally invasive techniques represent a major paradigm shift in the approach to surgical management of rectal adenocarcinoma. Laparoscopic, robotic, and recently transanal excision have emerged as alternatives to the conventional open approach. Rates of conversion to laparotomy is often cited as a surrogate for proficiency, and open conversions have been shown to have both short and long-term oncologic implications. However, to date, no large population study has analyzed how conversion rates have changed as utilization of minimally invasive techniques continues to increase. Moreover, no large population studies have examined short and long-term oncologic consequences of conversion from a minimally invasive approach. Thus, the primary aim of this study was to examine trends in minimally invasive technique utilization and rates of conversion to open in non-metastatic rectal cancer. Furthermore, this study aimed to investigate potential oncologic consequences in patients who undergo conversion to laparotomy from a robotic or a laparoscopic approach. This was a retrospective cohort study of clinical data from the National Cancer Database Registry from 2010 to 2016. The NCDB was reviewed for patients diagnosed with adenocarcinoma of the rectum or the rectosigmoid junction who underwent low anterior resection or abdominal perineal resection. Patients with stage 4 disease were excluded. The distribution of patients between surgical approaches is seen here. Among the patients who underwent a minimally invasive approach, no statistically significant staging differences existed between the robotic and laparoscopic approach, nor were there any differences in income or education. Relative to a laparoscopic approach, a robotic approach was significantly associated with a lower proportion of females and younger age. In the majority of patients in both the robotic and the laparoscopic groups, the primary tumor site was classified as rectum. In both groups, the procedure was classified as low anterior resection more frequently than abdominal perineal resection. From 2010 to 2016, the utilization of robotic and laparoscopic approaches significantly increased, while the utilization of an open approach significantly decreased over the duration of the study. The difference in rates of conversion to laparotomy between robotic and laparoscopic approaches was statistically significant. The trends in conversion rates for each approach are seen here. The robotic conversion to open rate did not significantly decrease over time. However, the laparoscopic conversion to open rate throughout the years did significantly decrease. Separate conversion subgroup analyses were performed for each approach with regard to primary tumor site and procedure. There were fewer conversions from a robotic approach than from a laparoscopic approach at the rectosigmoid and at the rectum. Additionally, there were fewer conversions from a robotic approach than from a laparoscopic approach for LAR and APR. Kaplan-Meier estimation illustrates survival in the figure seen here. 5-year overall survival for non-converted robotic, converted robotic, non-converted laparoscopic, converted laparoscopic, and open are seen here. Multivariable Cox proportional hazards regression further elucidated increased adjusted mortality hazard for the converted laparoscopy group relative to the non-converted cohort. No difference in adjusted mortality hazard was detected between converted and non-converted robotic cohorts, or converted laparoscopy and converted robotic cohorts. Multivariate analyses showed that robotic conversion was significantly associated with increased odds of 30-day mortality and 90-day mortality compared to the non-converted robotic group. Relative to the non-converted laparoscopic group, laparoscopic conversion was significantly associated with increased odds of positive margins, 30-day unplanned readmission, and 30-day and 90-day mortality. No significant difference in positive margins, negative circumferential resection margin, 30-day unplanned readmission, or 30 and 90-day mortality were seen between the robotic converted and laparoscopic converted groups. Numerous limitations existed in this study. Common to all retrospective reviews, this study was prone to selection bias and the potential for selecting patients with a more favorable BMI, tumor characteristics, or a less extensive history of abdominal surgery, which ultimately may have affected the decision of surgical approach and the threshold for conversion. Additionally, in the NCB, no data exists on the reason or timing of conversion in these approaches. Wide variation in surgeon experience within the various approaches likely existed, with no means in the database to control for years of experience or duration from residency or fellowship training to current practice. Finally, the NCDB does not include data on disease-free survival or recurrence rates, which would have been helpful in this outcomes analysis. This analysis of a large national oncology database demonstrated that the utilization of minimally invasive approaches to rectal adenocarcinoma are increasing, while the rates of open approach utilization are decreasing. A robotic approach was associated with significantly less conversions at the rectosigmoid junction, the rectum, and for LAR and APR. Moreover, we identified a statistically significant mortality hazard associated with conversion from laparoscopy to open that was not seen in conversion from the robotic group to open. Ultimately, these factors should be considered when deciding on a minimally invasive approach for the resection of rectal cancer. Thank you.